morning, everyone. I hope every year that we no longer have to do this and that I never seem to get my wish. You will all be getting my PowerPoints, so you don't need to take notes. And the other thing is, in the interest of time, I've included a lot of PowerPoints that I will skip over. They don't need an explanation, but I wanted you to have the full clinical picture, and the PowerPoints are important. So in today's presentation, I would like to give you all the tools to be able to interview a therapist for the appropriate treatment expertise in all areas of in all levels of alienation, and also to be able to discharge a therapist who is providing inappropriate treatment intervention, because this is a very specialized area. So the 4 areas that I will be focusing on is identifying the skills they need, although some have already presented those. Also to talk about some of the problems that the non-specialist in alienation does in the intervention that is actually contraindicated for the treatment of alienation. I want to identify what effective treatment is for all levels of alienation, and then demonstrate how you can use your patient bill of rights, which no therapist ever shares with you, by the way, from my experience, to hold the therapist accountable for appropriate intervention, and when they fail to do it, actually provide the legal grounds for the alienated parent's lawyer to go back to court and file a claim to have an appropriate therapist assigned, doing an appropriate intervention, and really putting the blame on the alienating parent for a change instead of the alienated parent. So what is the appropriate treatment for alienation? There are just so many choices, but there are major differences in the different interventions. Family therapy is the treatment of choice. Well, why is that? Well, family therapy abides by the standards of clinical care. It's the context that matters, or the total clinical picture. When a therapist just focuses on the severed or damaged parent-child relationship, they're only doing a partial job. The real emphasis has to be holding the alienating parent accountable. Nobody ever does that in traditional reunification therapy. That's like giving antibiotics to a patient with an infection and then returning the patient to the germ-infested environment that had caused the infection. Every time that child goes home to the alienating environment, they are reinfected. Family systems therapy has done a couple of things that are particularly relevant to the treatment of alienation. First of all, it changes the very narrow traditional focus on internal mechanisms such as a chemical imbalance, intrapsychic conflict, or historical factors as the cause of the identified patient's symptoms. Family therapy rejects this linear model and accepts instead a circular causation. That is, it's the here and now environment, the family interactional patterns that cause and maintain the identified patient's symptoms. And as my mentor, I was one who was trained by Salvador Minuchin. He said, children aren't orphans. It's the dysfunctional relationship that is the target for intervention, not the individual. And the treatment intervention is creating corrective family experiences. It's not a focus on insight or validation of feelings. This is a particular pet peeve of mine in traditional reunification therapy, having validation for the child's feelings based on distorted delusional beliefs. This is not therapeutic. This is anti-therapeutic that is often done. So these two main differences separate family systems therapy from every other form of treatment. The site of pathology is in the dysfunctional relationships, both with both parents, the pathological enmeshment with the alienating parent, and words are meaningless. It's creating corrective behavioral interactions. These are just some of the places which Dr. Burnett mentioned this morning, the 1950s. Family therapy grew out of the study of psychotic child patients on the psychiatric ward. And also my mentor at the Wiltwick Residential Treatment Center for Boys in New York. They noticed that the psychotic children would improve on the ward and then regress after visits. So they began to observe the visits, and this is the typical triangulation that Dr. Burnett pointed out that they observed. So mom and dad would get into an argument, and one of the parents, in this case mom, but fathers do it equally, I have to say, that's what the research shows. Mom entices Jane to form a coalition with her to denigrate and dismiss the other parent. This is what they call triangulation. Triangulation is crazy making for the children, and this is what family therapy said was the root of the child's psychosis, not a chemical imbalance. Psychosis or craziness is the result of a catch-22, no-win situation. When the child was co-opted by the triangulating parent, the child could not resolve that seduction, which is what I call it, and have a relationship with both parents, because either the child then rejected the other parent, or in the rare situation when the child could resist the triangulating parent, that parent would reject the child. So the child had no win basis of having two intact relationships with parents. Does this sound familiar? Family therapy's reframe from linear causation to circular causation freed the child from mental health diagnoses such as psychosis, which family therapists said is a misdiagnosis. If a symptom is situationally caused, then it cannot have the label of psychosis. And this is another pet peeve of mine with the way alienated children are treated, because then they are put on psychotropic medications, which are really unnecessary. Those medications cause a chemical imbalance. The child's symptoms are a result of the situation of triangulation. That is not a chemical imbalance and should not be treated as such. When the traditional therapist and their cohort psychiatrists join together to medicate your alienated children, they are making two severe failures in the standard of clinical care. When you have a symptom, it is the obligation of the clinician to generate all plausible hypotheses. It's pure speculation to say, well, the child's saying, I hate that parent, they terrify me. They haven't seen the parent in 4 years, but they're terrified at the mere thought of facing that parent in the context of a therapy session. Well, I have a bridge to sell to you in Brooklyn, if you believe that. I believe it's the loyalty conflict that puts the child in the middle of having to choose one parent over the other that causes these symptoms. What do you want to do? Cut off your right arm or your left arm? That's what this choice does. And the other failure is to consider the total clinical picture. That means the context for the child's symptoms. Isn't it amazing how all your children are healthy and normal and functioning well prior to the onset of the alienation? They only develop these symptoms after the alienation starts. Where is the causal connection? These therapists, in my mind, are committing malpractice. They are not meeting the standard of care when they don't assess the historical development of these symptoms and rush to medicate your children. These are just some of the schools of family systems therapy. Any one of them is competent to treat alienation. I just feel very comfortable with my makeup in structural family therapy as founded by my mentor, Salvador Minuchin. So family therapy says it does take two to tango, even though every family may have a different dance. We do believe that the truth lies in the middle, and we do believe in the 50-50 rule of relationships. However, it's only 50-50 until it isn't. Every clinical situation has an exception to the rule. And therapists who say they practice family therapies do not pay attention that alienation is an exception to the rule. Because it's child abuse, alienation is the exception to the 50-50 rule. When one parent behaves like this and makes the other parent behave like this, it is not a 50-50 relationship. And what I'm talking about here is the research we have on severe alienators, and I believe many moderate alienators as well, that they likely have more than one and up to 3 cluster B personality disorders. Personality disorders are an exception to the 50-50 rule. And this is some of the research. This is actually research by the hybrid people who maintain both parents contribute. They don't follow their own logical conclusions to the end. This is more of some of the contributors who say that. And this is my personal favorite, as discussed this morning by Clower and Rivlin, who followed 1,000 children for more than 30 years and talked about programming and brainwashing parents, and even described some of their behaviors as sociopathic. These are very good references to use in court to establish this is not a case of 50-50. Both parents didn't contribute. Alienators are severely disturbed. So I'm not going to go too much into personality disorders, other than to say they are a great variance with the cultural norms and expectations of their environment. And they are very good at mimicking normal behavior. And that's how they fool you, and that's how they fool a lot of people like me when I first started learning this, and a lot of other professionals. They are indeed wolves in sheep's clothing, and you have to know this. There are 4 cluster B personality disorders. We find that 3 are the most common in these cases: borderline, narcissistic, and antisocial. And borderline personality disorder has a great disturbance in interpersonal relationships and self-perception. You can get all of this out of the DSM. I want to run over this because I have more important points to make. and these are some of the criteria of a borderline personality disorder. I highlighted the recurrent suicidal behavior. This is what really scares me. They are the models for alienated children, and there is a very high correlation between a child developing a lot of these symptoms when they live with a borderline personality disorder. That's their role model. It is no surprise to me that suicidal ideation is very often a symptom that we see in severely alienated children. Again, you have to do a causal analysis as to where that behavior came from. And of course, we know the extreme splitting, I hate you, don't leave me. These are some of the sobering statistics on borderlines. Get this from my PowerPoint, but from the National Institute of Mental Health, suicidal gestures may be as high as 70 to 90%. Another serious reason that alienation is child abuse. This is what's being modeled for your kids. Narcissism, we know a lot about that. Lack of empathy. Interpersonally exploitative, I just wanted to focus on this, again from the DSM, because this is what they will do to your children. Narcissists will callously use your children as a means to hurt and punish you, completely unempathetic to the needs of their children. Poor parenting at the very least. The last one is antisocial personality disorder. Total disrespect for the rights of others and willing to break the law. The one that also scares me the most in this category is the repeated failure to conform to social norms, respect for lawful behaviors. When they violate the parenting plan, when they get your children to lie and make up false allegations of child abuse, these are serious behaviors that are child abuse. And again, I want to stress, we see this mostly in severe alienators. However, I've seen a lot of it in even moderate alienators. And this may be a reference that you also want to use when it comes to sociopaths. There is no known effective treatment for antisocial personality disorder. Do not try to save them. If you're the therapist, this is what you can do. Save yourself so you can help the kids. This is from a therapist, Shannon Thomas, from Texas. I think that's from Texas. Personality disorders will try to take over your sessions, manipulate counseling, and never underestimate their ability to triangulate people, including the professionals. That's the therapist, the GALs, the lawyer for the child. You need to be aware. You need to be able to use this research in court to educate the court about this. Very important information. This is just the prevalence of personality disorders in the general population. The populations we deal with, it's probably about double, maybe 20%. You will obviously see this more in prison populations, mentally ill patients. I believe any parent that tries to turn a child against a loving parent is definitely ill. And we also see that the professions of authority also attract this personality disorder, but all present company excluded. In sum, people with a personality disorder are experts at mimicking normal behavior, make the other feel he or she is the problem, denies any personal responsibility, is highly resistant to treatment. The last one, very important. It is a pleasure to observe a good attorney, undertaking a great cross of a personality disorder. They will decompensate on the witness stand with just a little bit of pressure, and why therapists don't know how to do it is beyond me. Someone may know some of the reference in this slide. It is important to understand that personality disorders are characterological. They're almost ingrained. In the DSM-4, it was on the Axis 2, which we no longer use. Axis 2 also had mental retardation, other characteristics that you can't change. That's how severe this is. On the other hand, while the alienated parent may present with the 4 A's, it is not characterological. It is a reaction to an abusive situation, and most therapists don't make that distinction. Be armed with this information. They need to assess how this person was prior to the onset of the alienation. So the 4 A's cannot be characterological if they're a reaction to the situation. Resolve the alienation, and most alienated parents I know became perfectly healthy and normal again. When therapists make the hybrid finding, which was referenced this morning, not by name, that both parents contribute, what's happening is they make 2 major errors. One is the cognitive error, where they fail to make a causal analysis of the parent's behaviors in relationship to the rejection. You can't have caused something if you're reacting to it. That's the first error that they make. The second error is the clinical error of failure to consider severity. Is the rejected parent's behavior in proportion to the extreme situation of a child rejecting a parent? We have all of Amy's research and more. Children don't reject parents. And they're certainly not going to reject parents because they didn't like the trip the parent took them on to Hawaii last year, which was actually said to me by 2 teenagers with a straight face. The long and the short of it is, hybrid cases are very, 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 very rare. And in case I didn't make myself clear, hybrid cases are very, very, very rare. You have to hold the therapist accountable to clinical and logical conditions and axioms, So when the family therapists, and they call themselves family therapists without the credentials, and I have a big issue with that, when they claim that most cases are hybrid cases, which the people in the Green Book do without connecting the dots, they are failing to consider the exception to the rule, that alienation is child abuse. And they weren't also personally trained by Salvador Minuchin. Traditional reunification therapy is contraindicated for severe cases, and I think it's really contraindicated for most cases because they don't address the alienating behaviors. That's the thread that must be consistent in all therapy. These are some more of the quotes from the hybrid people who don't seem to connect the dots. They also talk about here that traditional therapies don't work. And again, Clower and Rivlin, who I love, published by the American Bar Association, they say, in the introduction, our research continues to confirm, even when under court order, traditional therapies are of little, if any, benefit in this form of child abuse. Again, we need to call it child abuse so the court understands what this is. So what is the appropriate treatment for alienation? Does the severity of the alienation dictate different treatment interventions? Well, we know that diagnosis does dictate treatment, but the lines between moderate, mild, moderate, and severe are not clear. It's on a continuum. And you could have a mild to moderate case or a moderate severe case, and those are wildly different, and anything in between. Also, because we assess the level of severity by the intensity of the manifestations in the child, what happens if a mildly alienated child is under the influence of a severe obsessed alienator? Does anybody really believe that that child is not going to catch up to the severity of the alienator if there's no intervention? So how does one assess for the appropriate treatment for all these variables? Well, actually, the treatment does not change. It's the treatment environment that changes, okay? Whether or not you need a 90-day no contact period or a temporary transfer of custody. In every single case, you have to do two things. You do not just work with the relationship between the child and rejected parent. You have to have your focus on the alienator, the cause. So I'm going to skip over this because a lot of my colleagues have mentioned this, and I want to get to more important stuff. Unfortunately, most therapists you get don't know all those lists that everybody else has talked about. So I'm going to skip over this because you know what they don't do. Okay, I also may skip over some of the common mistakes they make. Again, is they focus on the symptom, not the cause. They fail to treat the underlying condition, which is the child abuse. They accept the alienator and child's reporting prima facie. When they do that, they are relying on what's called intuitive reasoning, that they believe the child and patient is telling the truth. That does not meet the standard of care. That's another failing. They have a responsibility to rely also on analytical reasoning. Both are important. System 1 and System 2. You can't deprogram a child because it's related to a cult. And this is some more information about a child's delusional thinking. It's a diminished capacity. It's a book written by Jamie Rosen, a lawyer in Family Court Review. This should also be used in court to explain to the lawyers why a child should not be taken seriously. The double bind. Science matters. This really irks me. You must accept your child's feelings, even though they're totally delusional, even though they believe you sexually abuse them, and you're supposed to acknowledge that so they have the same risk factors for PTSD as if it actually happened. Ask the therapist, what is the scientific basis of the therapeutic value of doing that? They can't tell you, there is none. That's very, very important, and I hear it all the time. It's reversal of family hierarchy, over-empowerment of the child. How many of you have heard, you're not my real mom or dad, I don't have to listen to you? Disempowerment of the alienated parent. And you can get this off from my PowerPoints. This also bothers me. Who's really in charge of the therapy? A therapist should not be allowing a child to decide if they're going to come, if they're going to walk out, if they're not going to talk, if they abuse you. This is antisocial behavior being sanctioned by the therapist. And when the therapist allows this to happen and let your child abuse you, this is not therapy. It's therapist-assisted elder abuse. And then when the therapy fails, inevitably you get blamed. Okay, I want to just move on. You have patient rights. This, I don't have time for all of it. There are standards of clinical care that you should be able to hold your therapist accountable to. There are codes of ethics by every professional organization that your therapist belongs to. There are state guidelines that govern the standards of care, and insurance companies do the same thing. I just here focused on the American Medical Association. You go through this, it talks about a collaborative effort. When have you been asked to participate in your treatment plan with definite behavioral changes with timelines? That's their obligation. You can go through this. One of my biggest pet peeves is that they are operating and practicing outside their area of expertise. This is not permitted. It's not permitted by the state that govern them. It's not permitted by the Patient Bill of Rights, either by the AMA or any mental health organization. Here's the American Psychological Association's Code of Ethics. They have to operate within the boundaries of their competence. What does that mean? They need to be able to tell you they recognize the 8 manifestations. How do you rule out for alienation if you don't even know the manifestations? Who do they collaborate with? How do they stay current? They have an obligation to stay current. You have a right to ask them of this. Do it nicely, please. And if you don't know how to do it, get some coaching from my wonderful colleagues here who do that. I don't do it because I'm too much of a, well, anyway. They have a right, you have a right to be respected. One of the other standards is you have an obligation as a patient to be forthcoming and truthful about your history. Why aren't they holding the alienating the parent accountable to that? They should be confronting the alienating parent with any misinformation that they give you about the child who's in therapy and about the reunification therapy. These are absolutely your rights. This is, I just pulled this off the internet. You can all get this. United Healthcare's website. This is an audit tool, okay? There are 93 questions in here that address your rights as a patient. You're entitled to develop behavioral goals with timelines that you participate in. You are entitled to have a review of them. Did anyone, even who was ever in therapy, ever get a written contract like this that defined, I didn't, I'm the first one to admit it. Nobody gave this to me. But this is your right, and you can hold them accountable to this. So it's very important. Every mental health plan has this. You should get it. You should also get your state guidelines that also talk about your therapist competency and hold them to it. These are grounds when they don't meet it to file a modification to get an appropriate therapist assigned. So I'm going to flip through these. This is, your health plan is not called venting abuse. It is a behavioral plan. And I have never seen an insurance plan that gave coverage for a therapist to support my child abusing me. So imagine your medical doctor saying to you, 5 more minutes, imagine your medical doctor saying to you, you better do what I say, and if you don't do it, I'm going to diagnose you with oppositional defiant disorder. Or I'm going to get you in trouble with your children. I mean, if you compare what a medical provider does with what these mental health clinicians are doing, well, let's put it this way, if the medical field did it, it would be in chaos, and they don't do it. So let me just go ahead. So you have a treatment plan that you're entitled to get, and get it from the internet and from your state. Okay, this is what your therapist should be doing. The process must be civil before content is addressed. We're clinicians that are supposed to support socially appropriate behaviors. That's number one. Why aren't they doing it? So civility means code of conduct. Hello, please, child, know your place. Therapists have a responsibility to require parental responsibility. They must require the alienating parent to send their child into a session to behave civilly. Teaching children how to behave begins at home. And we all do that in war. Well, George Washington knew it during war. Why can't we know it during divorce? When a child misbehaves, therapists must hold the alienating parent accountable for corrective action. The alienating parent is the one with leverage. Parental competency means leverage to use children to do what you expect them to do. And if they can't exert competency on that basis alone, they shouldn't be the residential parent. Alienating parents must be judged by their behavior, not by toothless words. Therapists must require behavioral changes. Feelings take time to change, but behaviors change immediately with proper consequences. Therapists must challenge the pathological enmeshment. This is a severe psychiatric condition. Why aren't they addressing it? They should be helping to teach boundary violations. Alienated families don't know about boundary violations. Therapists must challenge the pathological enmeshment by assisting the alienating parent to help children establish healthy boundaries. Therapists must help the alienated parent to correct and validate the child's revisionist history. Falsehoods repeated over time may become the child's reality unless a trusted adult challenges the distortion with repetition, reason, and respect. Monica Logan, Texas Premier Counseling. This is what has to be challenged. So I have my own treatment plan. Since by definition, alienation means there's no protective reason for you not having time with your child. So according to me, in week 1, this is the visitation plan the therapist must establish according to the court order, which they have to abide by. Alienated parent has dinner with children on all days of the court-ordered parenting plan. Alienated parent has full-day visits on all days. That's week 2. Alienated parent has full-day visits on all days of the court-ordered parenting plan. Week 3, alienated parent has overnight visits on all days of the court-ordered parenting plan. Week 4, alienated parent resumes full access to children as ordered by the parenting plan. No protective reason. No reason why a therapist shouldn't insisting on this. Week 5, attorney for the alienated parent files contempt motion against the alienating parent for failure to comply with the therapist treatment plan to comply with the court-ordered parenting plan. The difference is now the alienating parent is blamed for the failure of the treatment, not the alienated parent. Healthy family hierarchy is the obligation of every therapist to establish. Competent therapists demand healthy family hierarchy. If the plan doesn't work, change the plan, never the goal. And the therapist's job isn't done until this happens.